everyone, and welcome back to PodBites, where your platelets are low but your vibes are high. Wait, what? Oh, sorry. Hello, everyone, and welcome back to PodBites, where we break down complex medical topics into bite sized pieces, perfect for your commute, coffee break, or whenever curiosity calls. I'm Malak Hassan, and joining me today is the lovely Noor Elabd. Today, we're talking about why some people bleed too much, why others clot too much, and how to not get completely lost in the words hemostasis, hemophilia, von Willebrand, antiphospholipid, all of that stuff.
If you're listening to this in the gym, whilst driving, or half asleep, don't worry. We'll go step by step as if you've never heard any of this info before. No prior hematology trauma required.
Let me read you a little story. Imagine a 4-year-old boy. A few weeks ago, he had a flu-like illness, fever, cough, runny nose. He got better. Now, about 3 weeks later, his parents bring him in because they suddenly notice his legs are covered in tiny red spots. He bruises from the slightest bump, and he had a nosebleed that wouldn't stop bleeding for several minutes. Dude, why can't I have a happy ending?
Okay, Malak, don't cry. We've literally just started the episode.
Sorry. Pediatric patients are always a kick to the gut. All right, poker face on. The CBC comes back, hemoglobin normal, white cells normal, but platelets are 15,000. PT and APTT are both normal.
So, we have a small child, recent viral infection, now covered in little red spots known as petechiae, with very low platelets but normal clotting times. That is a classic picture of acute immune thrombocytopenic purpura or acute ITP.
Before we explain ITP, let's zoom all the way out, because absolutely none of this will make any sense unless we first understand how the body normally stops bleeding.
So basically, hemostasis is just a fancy word for how your body stops bleeding without just clotting everything off. You can think of it as three musketeers trying to fix a leaky pipe. Number 1, the vessel wall itself, the pipe. Number 2, the platelets, first responders like people quickly slapping duct tape over a leak. And finally, number 3, the coagulation factors, the cement crew that comes later to turn that duct tape plug into solid permanent repair.
We usually call the platelet part primary hemostasis and the coagulation factor part secondary hemostasis. And this is actually super important because diseases that affect primary hemostasis look very different from diseases that affect secondary hemostasis.
Let's say you cut your finger.
Ouch!
We're going to zoom in to your blood vessels to see how it reacts in some simple steps. Firstly, the blood vessel constricts. The muscles in the vessel wall squeezes down and narrows the opening. That reduces blood flow and buys time. Next, some of the inner lining of the vessel, the endothelium, gets damaged and the layer underneath is exposed. That layer includes collagen and a protein called von Willebrand factor or VWF.
Yes, remember collagen and von Willebrand factor. Now, von Willebrand factor is like sticky glue that sits on the damaged area. The platelets swimming by have a receptor on their surface called glycoprotein 1b. So von Willebrand factor grabs glycoprotein 1b, and suddenly the platelet is stuck to the site of injury. That step is called adhesion.
Once a platelet sticks, they get very dramatic about it. They change shape from smooth little discs into spiky balls. This increases their surface area and makes them better at interacting with other cells and proteins. They also turn on other new receptors like GP2B and GP3A on their surface. We'll come back to that in a second. Also, inside the platelets, there are granules loaded with chemicals. When platelets get activated, they release these granules. Some are alpha granules with von Willebrand factor, fibrinogen, and other proteins, and some are new dense granules, which contain ADP, calcium, serotonin, etc.
ADP and thromboxane A2, which are both produced by platelets, act like group chat notifications. They tell nearby platelets, "Hey, we've got a wound here, come help us out." More platelets get activated and recruited.
Once lots of platelets show up and are activated, they need to link together. That's where GP2B and GP3A we talked about earlier comes in. These receptors bind fibrinogen, and then fibrinogen acts like a bridge connecting one platelet to another. This step is aggregation, and when enough of them clump, you get a platelet plug, the quick temporary seal by duct tape at the site of injury. A quick mnemonic that can help you remember is GP1B because you have one platelet binding to the vessel wall, and GP2B because you have two platelets binding to each other. Very simple.
So, if your von Willebrand factor is abnormal, or glycoprotein 1b is missing, or glycoprotein 2b3a doesn't work, or you don't have enough platelets, you can't do that first emergency patch properly. That's when we say there's a primary hemostasis problem. And the bleeding pattern you see is typically mucocutaneous. Nosebleeds, gum bleeding, heavy periods, and tiny pinpoint skin spots called petechiae.
Okay, now remember our three musketeers trying to fix a leaky pipe? The vessel wall itself, the platelets, and number 3, the coagulation factors. So let's start with the first one. When the problem isn't the platelets, it's the vessel wall itself. For example, in Ehlers-Danlos syndrome, collagen is abnormal. Collagen usually helps give blood vessels strength, so if collagen is weak, vessels are fragile and you get bruised easily. A second example is Henoch-Schönlein purpura. In this condition, immune complexes containing IgA deposit in small vessels. That triggers inflammation and damage of the vessel wall, causing leakage and those classical palpable purpura, especially on the legs. Another example is scurvy.
Ahoy there, matey. Sorry, I just think of pirates whenever I hear scurvy.
Okay, please don't ever do that again. Anyways, in scurvy or vitamin C deficiency, you can't make strong collagen because vitamin C is needed for a step in collagen synthesis. So again, no strong collagen means capillaries become fragile and you see gum bleeding, and you even get small perifollicular hemorrhages around the hair follicles.
Those are technically primary hemostasis issues too, because they affect the first step, the vessel wall. But now, we'll mainly focus on platelet and clotting factor disorders because they come up a lot in exams and in clinical practice. Back to our young patient with platelets of 15,000. Is that super low? Diabolically low.
Yeah, so a normal platelet count is around 150 to 400,000 per microliter, okay? Remember, 150 to 400,000 microliters. So above 150,000, everything is fine. Above 50,000, most daily activities are safe and even minor procedures are usually okay. But once you drop, let's say, between 20,000 and 50,000, you're at a higher risk of bleeding after trauma. So if you bump into something or let's say have a surgery, you might bleed more than usual. Below 20,000, things start to get a little scary. At that point, platelet plug formation can fail even without trauma, and you get random bleeding, nosebleeds, gum bleeding, and in the worst case scenario, intracranial hemorrhage. Some guidelines consider counts below 10,000 as particularly critical.
But here's the key idea. We do not, and I repeat, do not just treat the number. We treat the person. If someone has a platelet count of 20,000 but is sitting comfortably, not bruising, not bleeding, you don't automatically grab platelets and start transfusing like there's no tomorrow. You need to look at symptoms and bleeding risk.
Exactly. Always treat the patient, not the number. It's true platelet counts tell you the risk, but the patient's actual bleeding tells you what to do next.
Okay. Now, let's clarify one of the most tested patterns. How bleeding from platelet problems looks different from bleeding due to clotting factor problems.
If the problem is platelets or vessel wall, so primary hemostasis, you see things like mucosal bleeding, basically from the nose, gums, or heavy menstrual periods, and skin findings like tiny petechiae, small purpura and bruising, and oozing from superficial cuts. If the problem is a coagulation factor problem, so secondary hemostasis, the platelets can still make its initial plug, but you can't stabilize it with fibrin. So you get deep bleeding, bleeding into joints, hemophilia and muscles. This is very important. Bleeding into the joints, hemophilia and muscles is a classical sign of deep bleeding or a problem with coagulation factors. You also get delayed bleeding after surgery, so it may initially stop, then start again as the fragile clots break down.
That's why you don't usually see petechiae in hemophilia. The platelets are fine, so small vessels are sealed, but you do see big, deep bleeds, especially into joints. Remember that.
To make sense of how serious the bleeding is, we can use bleeding grades. If someone has no bleeding, that's grade 0, even if the platelets are low. That reminds us that low platelets don't always equal active bleeding. Remember, treat the patient, not the number. If they just have mild stuff like small petechiae, mild menstrual spotting, that's grade 1. If there's obvious bleeding, say blood in the urine or vomit, but they don't need any transfusions, that's grade 2. If the bleeding is bad enough that they actually need transfusions of red cells, platelets, or plasma, that's grade 3.
And then there's grade 4, which is life or organ threatening. And this is when you need to lock in. Things like bleeding, causing shock, intracranial hemorrhage, or bleeding in the neck or throat that threatens the airway. One classical example people love to ask about is retinal hemorrhage with visual loss. Even though it's just in the eye, it can permanently blind the patient. Again, that counts as which grade?
Grade 4. So if you see a question about retinal hemorrhage and visual loss in context of bleeding disorders, think, okay, it's most likely the most severe grade, grade 4.
All right. We know our young patient has low platelets, but in general, why might someone's platelets be low?
Well, there are 4 main themes: decreased production, increased destruction or consumption, sequestration, and dilution. Let's go through each case one by one. First cause of thrombocytopenia is decreased production in the bone marrow. Platelets are made from megakaryocytes, which live in the bone marrow. If the marrow is failing or crowded out, you can't make enough platelets. This happens in aplastic anemia, where the marrow stops working, or in acute leukemia or myelodysplastic syndrome, where abnormal blasts take over the marrow instead of normal cells. Vitamin B12 and folate deficiency can also cause ineffective blood cell production, including platelets, by the way, because DNA synthesis is impaired. Also, some infections and drugs can directly suppress the marrow. Second, we've got increased destruction or consumption in the periphery. These can be immune, like ITP, where antibodies tag platelets for destruction in the spleen, or non-immune, like in DIC, and TTP, where platelets are used up when making lots of small clots all over the body. And third, sequestration in the spleen. Normally, the spleen stores around a third of platelets, but if the spleen is enlarged, it can start trapping much more than needed. In hypersplenism, the spleen is big. At least one of the blood cell types, like platelets, red cells, or white cells, is low, and the bone marrow is normal, meaning production is fine, but the cells are getting stuck in the spleen instead of circulating.
So, if someone has splenomegaly, cytopenias, and a normal marrow, we call that hypersplenism, basically just a sequestration problem.
Exactly. And the fourth cause of thrombocytopenia is dilution, which happens when someone gets lots of red cell transfusions without platelets. Their blood volume goes up, but the absolute number of platelets hasn't increased, so the measured concentration drops. This is seen in massive transfusions, especially in trauma.
Usually when platelets are low, we think bleeding. But, funnily enough, there are some sneaky exceptions where platelets are low because they're all stuck in clots.
Most thrombocytopenias are associated with bleeding. When heparin-induced thrombocytopenia, or HIT, thrombotic thrombocytopenic purpura, TTP, and antiphospholipid syndrome, APS, the platelet count is low, but ironically the main problem is actually thrombosis. In HIT, the patient is on heparin, and their immune system forms antibodies against complexes of heparin and platelet factor 4. What do all these antibodies do? Those antibodies activate platelets, which then start to form clots all over. The platelets get used up in these clots, so the count drops. But the big clinical issue is still what? Clotting. In TTP, a deficiency of the enzyme ADAMTS13 leads to the ultra-large von Willebrand factor multimer that causes platelets to clump in small vessels, forming microthrombi and consuming platelets. In APS, you have antiphospholipid antibodies that promote clotting and also destroy platelets. So you can get low platelets plus thrombosis.
So, if you see low platelets plus thrombosis instead of bleeding, start thinking about those three: HIT, TTP, APS. A lot of acronyms, I know.
Now back to our case. Putting all this together, our 4-year-old has low platelets, mucocutaneous bleeding, petechiae nosebleeds, normal PT and APTT, recent viral infection, and he's a child in the classical age range between 2 to 5 years old. That fits acute ITP perfectly. The immune system, after fighting the virus, accidentally starts making antibodies that stick to platelet surface proteins. Those antibody-coated platelets go to the spleen and get eaten up by macrophages. The bone marrow tries to compensate for these platelets by making more megakaryocytes. But unfortunately, destruction is faster than production, so the platelet count stays low.
So, we know acute ITP now, but how is this different from chronic ITP in adults?
Well, in acute ITP like our case, it usually happens in children, often after a viral infection or vaccination, and it tends to resolve within a few months. And boys and girls are affected equally. In chronic ITP, it's more often seen in young or middle-aged adults, especially in women. There's usually no recent infection story, it just creeps up out of nowhere. Months of easy bruising, nosebleeds, and gum bleeds. It lasts more than 6 months and doesn't spontaneously resolve as often. It may be primary, where it's just ITP, or secondary, where it's associated with other autoimmune diseases like lupus, HIV, or CLL.
So, what do we actually do for the kid?
Well, in acute ITP, the goal is to prevent serious bleeding, not to force the platelet count to be perfect. In children with acute ITP and significant bleeding or very low counts, we often use IVIG, which is intravenous immunoglobulin. Remember, in ITP, the immune system makes antibodies that stick to platelets. Macrophages in the spleen have Fc receptors that recognize these antibody-tagged platelets and destroy them. And an IVIG helps because it floods the bloodstream with normal antibodies. These antibodies occupy or block the Fc receptors on the splenic macrophages. Since the macrophages receptors are busy, they don't destroy platelets as much, and thankfully platelet levels rise. Think of it as distracting the spleen's cleanup cells so they stop removing platelets.
So, it floods the system with normal antibodies that block the Fc receptors on splenic macrophages, so they don't clear the platelets as aggressively, right?
Exactly. And steroids like prednisolone are another option. They reduce the production of autoantibodies by B cells and make macrophages less active. Steroids are especially important in chronic ITP. In more stubborn chronic cases, we can also use rituximab, which is an antibody against CD20 on B cells, reducing the autoantibody producing cells. Or we can use thrombopoietic receptor agonists like romboplastin or L-trombopag, which tells the bone marrow to crank up platelet production. Splenectomy is an option when all else fails, because removing the spleen removes the main site of platelet destruction and some antibody production. But it comes at a cost of higher risk of serious infection with encapsulated bacteria, so we vaccinate and are especially cautious in children.
Okay, so IVIG, steroids, rituximab, and thrombopoietin receptor agonists, or splenectomy. And what about platelet transfusion?
Platelet transfusion in ITP is like sending more victims into a war zone. The antibodies will just attack the poor transfused platelets too. So we do not routinely transfuse platelets in ITP. We reserve platelet transfusions for life-threatening bleeding like intracranial hemorrhage, where we just need something to work for long enough to stabilize the patient. So for our child, we recognize this as acute ITP, understanding that his platelets are being destroyed by his immune system, and we treat with things like IVIG or steroids if needed, while remembering that platelet transfusion is not the standard answer unless bleeding is severe.
And that's why this child had those petechiae and nosebleeds. His primary hemostasis was compromised because his platelet count was severely low from immune-mediated destruction. Wait, before we leave primary hemostasis, what about when platelet number is normal, but their function is broken? Like when the platelets aren't doing what they're supposed to do?
Good question. This is also very, very important. Two classic inherited function disorders are Bernard-Soulier syndrome and Glanzmann thrombocythemia. In Bernard-Soulier, the problem is the GP1B receptor on the platelet. Remember that the receptor von Willebrand factor binds to it for adhesion. If GP1B is missing or defective, platelets can't stick properly to the damaged vessel wall. So adhesion, the very first step, fails. Platelets often look large. You see giant platelets on the smear, and patients bleed like any primary hemostasis defect, mucosal bleeding, easy bruising, and prolonged bleeding time. In Glanzmann, GP2B and GP3A is missing or defective. That's the receptor needed to bind platelets to fibrinogen and glue platelets together. So adhesion is fine. They can still stick to the vessel wall, but aggregation is broken. Again, bleeding is from the mucosa and skin. And here you'll see prolonged bleeding time, but the platelet count is usually normal. So to recap, in both Bernard and Glanzmann, you'll have a problem in the function and you get prolonged bleeding time, but normal platelet count.
Exactly, but just a minor point. Sometimes in Bernard-Soulier, because platelets are large, remember, giant platelets, automated counters may miscount them, so it looks a bit low. So, platelet count could be normal to slightly low. Anyway, remember that Bernard-Soulier is an adhesion problem because of glycoprotein 1b, and Glanzmann is an aggregation problem because of glycoprotein 2b, 3a. They literally had one job and decided to be like, nope. Now let's move to our next case. Picture a 20-year-old woman who's had heavy periods since menarche, frequent nosebleeds since childhood, and bruises easily. She's otherwise healthy. CBC is normal, platelets are fine, PT is normal, but bleeding time and APTT are slightly prolonged. And a test for von Willebrand factor antigen comes back low. Factor VIII levels are also mildly reduced.
This is a classic setup for von Willebrand disease.
So now we get to talk about one of the stars of hemostasis, von Willebrand factor. Fancy name. So, what exactly does it do?
Well, von Willebrand factor has two very important jobs. Firstly, it helps with platelet adhesion. It binds exposed collagen in the damaged vessel wall on one side and binds platelet GP1B on the other. So it's like a double-sided tape that allows platelets to stick to the injured area like a plaster. This is primary hemostasis function. Secondly, it acts as a carrier protein for factor VIII in the plasma. Factor VIII is a clotting factor in the intrinsic pathway. On its own, it would get degraded quickly.
Poor guy.
Literally. Usually, von Willebrand factor protects it and keeps it circulating. So that's a secondary hemostasis function for von Willebrand factor.
So, if von Willebrand factor is low or not working, firstly, platelets can't stick well. And also, factor VIII gets degraded, so its level drops.
Exactly. That's why von Willebrand disease is a disorder that causes both platelet-type bleeding, mucosal, and in more severe cases, deep bleeding like hemothyrosis, because factor VIII levels can become quite low. There are different types of von Willebrand factor deficiency. Type 1, it's partial quantitative deficiency. Von Willebrand factor is there, but in reduced amounts. Type 2 is a qualitative defect. The von Willebrand factor is present, but doesn't work properly. And type 3 is a virtual absence of von Willebrand factor. This is the most severe form.
So, in our patient, the heavy periods and nosebleeds fit a primary hemostasis defect, while the mildly prolonged APTT and low factor VIII suggest involvement of the secondary hemostasis intrinsic coagulation pathway. Wait, hold on. Can we quickly explain what all the tests like BT, PFA 100, PT, and APTT actually measure?
Good idea, let's do it. Bleeding time, BT, and PFA 100 both check primary hemostasis, meaning how well platelets can form the initial plug. BT is the old manual method where you make a standardized cut and time how long it takes to stop the bleeding. But since that's inconsistent, the PFA 100 is now preferred. It puts blood through tiny artificial opening and measures how long it takes platelets to close the hole. These tests assess platelet function, not platelet count, though extremely low platelet numbers can indirectly prolong them simply because there aren't enough platelets to work with. Meanwhile, PT, or prothrombin time, checks the extrinsic pathway of secondary hemostasis. And the easiest way to remember is that PT, T for tennis, you play outside, so extrinsic. And APTT, activated partial thromboplastin time, checks the intrinsic pathway. Remember it as APTT, TT for table tennis, you play that inside, so intrinsic. So to put it simply, BT or PFA 100 assesses platelet plug, and PT assesses extrinsic, and APTT assesses the intrinsic pathway. So for our patient, her labs fit the von Willebrand factor deficiency, normal platelets, normal PT, prolonged bleeding time, and PFA, sometimes prolonged APTT, low von Willebrand factor antigen, and low factor VIII.
Okay, so now that we understand the problem is von Willebrand disease, how can we help her?
One really useful drug is desmopressin, often called DGAVP. Desmopressin tells endothelial cells to release von Willebrand factor and factor VIII from storage granules called Weibel-Palade bodies. This temporarily boosts both von Willebrand factor and factor VIII levels in the blood. This works particularly well in type 1 von Willebrand disease, where the von Willebrand factor is normal but reduced in amount. In more severe types, like type 3, where von Willebrand factor is absent, desmopressin won't help as much because there isn't enough stored to be released. In those cases, we give von Willebrand factor and factor VIII containing concentrates or cryoprecipitates during bleeding or before procedures.
So, in our case, von Willebrand disease explains all of her symptoms. The platelets can't stick well due to low von Willebrand factor, and factor VIII is lower than normal, adding a mild secondary hemostasis defect. And that is why she had mucosal bleeding and also the mildly prolonged APTT, and that's why desmopressin helps. It boosts von Willebrand factor and factor VIII from their storage sites. Our next case is a 5-year-old boy brought in after circumcision as a baby. He bled for a long time and needed hospital care. Now, at age 5, he's having repeated painful swelling of his knees and ankles. CBC is normal, PT is normal, but APTT is clearly prolonged.
This is the classic picture of hemophilia, most commonly Hemophilia A, which is a factor VIII deficiency, or Hemophilia B, which is a factor IX deficiency. Clinically, you can't really tell the difference between A and B without testing specific factor levels.
Now, we're mainly dealing with secondary hemostasis, right?
Yes. Think of secondary hemostasis as a cement crew. Once platelets form a plug, secondary hemostasis uses the coagulation cascade to form fibrin, which acts as concrete stabilizing the plug. The intrinsic pathway uses factor 12, 11, 9, and 8. Just count down from 12, but skip 10. The extrinsic pathway, on the other hand, mainly uses factor 7 and tissue factor. Both meet at the common pathway where factor 10 gets activated, which helps convert prothrombin, factor 2, into thrombin, and thrombin converts fibrinogen into fibrin. So 12, 11, 9, and 8 is
Intrinsic.
And factor 7 plus tissue factor is
Extrinsic.
Exactly. In Hemophilia A, factor 8 is missing or low. In Hemophilia B, factor 9 is missing or low. Both are X-linked recessive, so they almost always affect which gender?
Males.
Exactly, males. And even carrier mothers may have affected sons.
That explains why more than 80% of hemophilia patients are male.
Precisely, because factor 8 and 9 live in the
Intrinsic pathway.
The APTT will be prolonged, while PT remains normal. Platelets are fine, so platelet count and bleeding time are both normal. Clinically, these children have deep bleeding, repeated joint bleeds, hemothyrosis, often knees first, then ankles, hips, and then shoulders. They also get muscle hematomas and prolonged bleeding after surgeries.
Let's explain why joints specifically, though. Why do they get hemarthrosis?
Joints are constantly under small stresses and micro trauma from walking, running, and playing. In a normal person, any tiny bleed is rapidly stabilized. In hemophilia, however, that stabilization fails because the fibrin mesh is weak. So a tiny joint bleed can keep expanding. Blood in the joint is irritating and triggers inflammation, synovial thickening, and over time, cartilage damage and fibrosis. Repeated episodes slowly destroy the joint, causing deformities and disability. That is why prophylactic factor replacement is really important, not just to stop the bleeding, but to protect the joints long term.
And how do we measure how bad the hemophilia is?
We look at the factor level as a percentage of normal. If factor 8 or 9 is less than 1%, that's severe hemophilia. These patients can bleed spontaneously without trauma and especially into the joints. If the level is between 1 and 5%, that's moderate. They bleed with mild injuries. Above around 5%, we call it mild hemophilia. These patients bleed mainly after surgery or after significant trauma.
What do we actually give them?
Well, in Hemophilia A, we give factor 8 concentrates. In Hemophilia B, we give factor 9 concentrates. In resource-rich settings, patients are put on regular prophylactic factor replacement to keep their levels above 5% most of the time, so they don't just get spontaneous hemothyrosis and long-term joint damage. Factor VIII has a half-life of around 8 hours, so during active bleeding, you might have to give it 2 to 3 times a day. Factor IX, however, has a longer half-life, about 12 hours, so it can be given less frequently. Remember, 9 is greater than 8, so factor IX has a greater half-life. Also, in some patients, especially with those with hemophilia A, the immune system can recognize the infused factor VIII as foreign and form antibodies against it. That makes treatment more complicated, and a higher dose or special bypassing agents like activated factor VII may be needed.
Yes, that's because sometimes giving more factor VIII doesn't help. It just gets attacked too. So, we need a way to generate thrombin without needing factor VIII or factor IX, and that is where factor VIIa comes in. It's a bypassing agent, meaning it bypasses the missing intrinsic pathway. Now, imagine an exam asks you, a 5-year-old boy with repeated knee bleeds, normal CBC and PT, prolonged APTT, what is the most likely diagnosis? And they give you options like hemophilia A, hemophilia B.
Even though both A and B fit the pattern, the most likely answer is usually hemophilia A, because it's much more common than hemophilia B. So if they offer hemophilia A as an option, that's the one you pick. That's a very high yield twist.
Now, hemophilia is an inherited problem. But what about acquired coagulation disorders? Let's talk about vitamin K and liver disease.
Vitamin K is essential for an enzyme in the liver that gamma carboxylates certain clotting factors. Gamma carboxylation is a chemical change that lets those clotting factors bind calcium and stick to the phospholipid surfaces. Without that step, there's no point because the clotting factors are made but won't work properly. The vitamin K dependent factors are 2, 7, 9, 10. Repeat after me.
2, 7, 9, and 10, plus protein C and protein S.
So vitamin K deficiency, all of those are functionally reduced. Where do we get vitamin K? From green leafy vegetables in the diet and from the gut bacteria that synthesize it. So deficiency can happen in malnutrition, in malabsorption states, in biliary obstruction where fat-soluble vitamins aren't absorbed, or heavy antibiotic use that wipes out the gut flora. Also, newborns are a special case. They are just born with low vitamin K stores. Their gut is sterile at first, and breast milk doesn't have huge amounts. That's why we give vitamin K injections at birth to prevent bleeding in the first days of life, known as hemorrhagic disease of the newborn.
And how does liver disease fit in?
Well, the liver produces most of the clotting factors, plus regulators like fibrinogen and protein C and S. When the liver is damaged, say in cirrhosis, it can't produce enough of them. That leads to a complex coagulopathy, often with both PT and APTT prolonged, because those intrinsic and extrinsic pathways are affected. Add to that the fact that the liver diseases can cause portal hypertension and splenomegaly. Leading to platelet sequestration and thrombocytopenia, you have multiple hits to hemostasis all at once.
Now, let's switch gears from bleeding to clotting. Here's our next case. Are you ready? This is a 32-year-old woman, previously healthy, comes to the clinic after her first trimester miscarriage. She also mentions having a strange, net-like purplish pattern on her legs that comes and goes. We call that livedo reticularis. A year ago, she had a deep vein thrombosis in her leg. Lab tests show a mildly low platelet count and a prolonged APTT, but she is forming clots, not bleeding. Further tests show positive anti-cardiolipin antibodies and a positive lupus anticoagulant.
This is a classic scenario of antiphospholipid syndrome or APS.
Before we explain APS, let's talk about what makes clots form in general. That's where Virchow's triad comes in.
Virchow's triad is the 3 pillars of thrombosis. You can remember them as 1. Endothelial injury. You get damage to the inner lining of the vessel, like from surgery, inflammation, or atherosclerosis. It exposes collagen and von Willebrand factor and removes some of the endothelium natural anticoagulant properties like nitric oxide and prostacyclin. Number 2, abnormal blood flow. That means stasis. Slow, not moving much, like in a leg vein of someone who's been immobilized. Or turbulence, chaotic flow around plaques or in aneurysms. Normal flow keeps clotting factors diluted and platelets away from the wall. Abnormal flow lets them pile up and activate. And 3. Hypercoagulable state, where the blood itself is more likely to clot. That can be inherited like factor V Leiden or protein C deficiency, or acquired like in pregnancy, cancer, or with certain medications.
So, if you have one component of the triad, your risk of thrombosis goes up a little bit. At a second, it rises more. If you have all three, damaged endothelium, sluggish flow, and hypercoagulable blood, your risk of a clot is very high, and all three can be caused by smoking. So, stop smoking.
One of the most important inherited causes of a hypercoagulable state is factor V Leiden. Normally, factor V participates in turning prothrombin into thrombin. Once the job is done, it gets turned off by activated protein C, or APC. APC is like OK, stop now signal. It inactivates factor Va and factor VIIIa, shutting down the coagulation cascade once a clot is formed. In factor V Leiden, there's a mutation in the gene for factor V that changes one amino acid. This little change makes factor V resistant to cleavage by APC, so APC can turn it off properly. That means factor V stays active for longer than it should, so more thrombin gets produced.
And clots are more likely to form.
Exactly.
So, people with factor V Leiden are especially prone to venous thrombosis, especially if they have another risk factor like immobilization or pregnancy.
Yes, especially if they're homozygous for the mutation, their risk is significantly higher. The routine clotting tests like PT and APTT are often normal because routine PT and APTT tests only measure how long it takes to form a clot. Factor V Leiden does not slow down clot formation, it actually increases the clotting ability. So, there's no deficiency of any factor. The pathway, intrinsic and extrinsic, work normally. The clot still forms at a normal speed. Therefore, PT and APTT remain normal. So you need special tests or genetic testing to diagnose it. And we don't put everyone with factor V Leiden on lifelong anticoagulation unless they actually develop thrombosis. If they do, we use long-term oral anticoagulants like warfarin or direct oral anticoagulants.
Let's go back to our patient with miscarriages, livedo reticularis, and a previous DVT. Her labs show prolonged APTT, but she's clotting, not bleeding. That feels weird at first glance. Isn't prolonged PT and APTT a sign of slower clotting?
It does, and that's the famous paradox of antiphospholipid antibodies.
So, what happens? These antibodies attack phospholipids?
Not exactly. It's more that they attack the proteins that cling to the phospholipids, like the bodyguard standing on the membrane. When those proteins get attacked, the whole system becomes unstable.
So, the antibodies are like, I'm not here for the floor, I'm here for the guys standing on the floor?
Exactly. That's why they're called antiphospholipid antibodies, because the proteins they target happen to be attached to phospholipids. When these membrane-associated proteins get attacked, endothelial cells become prothrombotic, platelets activate, complement activates, and XM5 protection disappears, causing fetal loss, and protein C pathways get disrupted, causing more clotting. That's why APS causes clots in real life. So these antiphospholipid antibodies are autoantibodies that bind proteins that interact with phospholipids, not the phospholipids themselves. The common ones are anticardiolipin antibodies, lupus anticoagulant, and antibodies to beta-2 glycoprotein 1. And here's a trick. In the lab, the antibodies mess with the test reagents, so the APTT looks prolonged.
Oh my god, like sabotaging a cooking show by unplugging the mixer?
Someone's been watching too much MasterChef. But, I mean, you could say that, I guess. But remember, in the body, those same antibodies actually activate platelets and the endothelium, so the person forms clots, not bleeds.
So, in the test tube, they look like anticoagulant agents, but in real life, they're prothrombotic troublemakers.
That's the APS paradox. Anticoagulant in the tube, procoagulant in the body.
So that's why she keeps clotting. She's forming DVTs and tiny placental clots.
Exactly. The antibodies can target protein C, weakening one of the body's natural anticoagulant brakes. They can target annexin 5, which normally protects the fetal side of the placenta by forming anticoagulant shield. When annexin 5 is blocked or removed, clots can form more easily in uterine and placental vessels. That can cause placental infarcts, fetal growth restrictions, and early pregnancy loss. They can also target beta-2 glycoprotein 1, which contributes further to the endothelial activation and clot formation.
So, as a recap, in APS you have this combination of venous or arterial thrombosis, recurrent miscarriages, often livedo reticularis, and interestingly sometimes thrombocytopenia, because platelets are being used up in clots and may be directly attacked. I have a question, Noor. Do people with antiphospholipid antibodies always get full-blown APS?
Not necessarily. The current thinking is that antibodies create prothrombotic tendency, but often need a second hit to trigger a clinical event like smoking, prolonged immobilization, pregnancy, the postpartum period, estrogen therapy, malignancy, nephrotic syndrome, hypertension, or high lipids. Some of these factors add on to the presence of antiphospholipid antibodies, the risk of thrombosis or pregnancy loss spikes.
That was a lot of factors. Now, let's talk about diagnosis. How do we diagnose APS?
To diagnose APS, you need both lab evidence and a clinical event. Lab-wise, you might see a prolonged APTT that doesn't correct with mixing studies, and you specifically test for anticardiolipin antibodies, beta-2 glycoprotein 1 antibodies, and lupus anticoagulant. At least one of these need to be present on more than one occasion. Clinically, you need either documented venous or arterial thrombosis, or certain types of pregnancy morbidity like recurrent early miscarriages. At this point, we call it antiphospholipid syndrome.
And as for treatment, if a person has had thrombosis, we give long-term anticoagulation with drugs like warfarin or sometimes direct oral anticoagulants.
But for women with APS who want to get pregnant or are pregnant, we cannot use warfarin during pregnancy because it's teratogenic. Instead, we use low-dose aspirin plus low molecular weight heparin, like enoxaparin. The idea is to sit on the clotting tendency just enough so the placental circulation stays open and pregnancies can be carried to viability.
Okay, that was a long ride. We've covered a lot and my back hurts already, so let's tie the cases back to the concepts. Our 4-year-old with spots had acute ITP, antibodies attacking platelets, causing low platelet count, mucosal and skin bleeding with normal coagulation tests. That is a primary hemostasis disorder due to platelet destruction. Our young woman with nosebleeds and heavy periods had von Willebrand disease, a problem with von Willebrand factor, leading to impaired platelet adhesion and mildly low factor VIII. She had mucosal bleeding and slightly prolonged APTT. Von Willebrand disease sits at the intersection of primary and secondary hemostasis. Now, our 5-year-old boy with joint bleeds had hemophilia, most likely Hemophilia A, a factor VIII deficiency in the intrinsic pathway. He had normal platelets and PT, but prolonged APTT and deep bleeding into joints and muscles, a pure secondary hemostasis defect. And finally, our 32-year-old woman with miscarriages, DVT, and livedo reticularis had antiphospholipid syndrome, antiphospholipid antibodies that paradoxically prolong APTT in the lab, but cause thrombosis in the body, leading to clots, pregnancy loss, and sometimes low platelets.
Yes, that's a very big story of hemostasis disorders. If the first responders, platelets, and vessel wall fail, you get mucosal bleeding, petechiae, and easy bruising. If the cement crew, coagulation factors fail, you get deep bleeds, hemothyrosis, and delayed bleeding. And if the system flips the other way and becomes too aggressive, especially with things like factor V Leiden or APS, you don't bleed, you clot.
So, next time you see bruises, nosebleeds, joint swelling, or recurrent miscarriages in a question stem, you can play detective. Is this primary or secondary hemostasis? Is it bleeding or clotting? Platelets, factors, or both?
And once you can answer that, half the battle on the exam questions and in real life is already over.
And that's it for today's episode of PodBites. Your platelets may be tiny, but their drama is huge. Seriously, get a grip on the endothelial wall. Stop trying to kill us. Thank you so much, Noor. Thank you to everyone for listening, and we'll catch you in the next one, inshallah.
See you guys.